here we go. So I was very reassuring actually to hear your talk, Pete, because it means that I'm actually doing retrograde nails in exactly the same fashion. So I feel I must be doing something right. And I just wanted to reiterate how important the lateral x-ray and that sandbag, or I use a sandbag under the ipsilateral buttock is, so you can get a true lateral x-ray. And distal femurs kind of fall, don't they, into a bimodal distribution. So you've got your young, high mechanism of injury, fall off motorbikes, and Ennis is going to talk about that. And I get sort of the unsexy side of it, which is elderly people that fall in their own homes, but are equally important. So we'll look at some cases and then try and draw some new conclusions at the end. This is our 85-year-old lady. AMT is 10. She falls in her own home. And obviously, she's going to be on warfarin with an INR of 2 for her atrial fibrillation. And she's got some leg ulcers. They're regularly dressed and they're coming up to her knees. Now, I'm sure you're going to look at that. And your exam answer is going to be, oh, you can't understand it. You need to get further imaging. She has to have a CT scan. But our radiographers are good. There's probably a reason this is the only imaging you've got, because it really, really hurts breaking your femur. I've broken mine, and this is probably the best x-ray you're going to get. So I would just, before you ask for those repeat x-rays, just ask yourself, are you going to gain anything, or can you actually take them to theatre and get all the information with traction reviews in theatre? Most of the time they are going to go into the joint, and as long as you have a plan A and a plan B, repeat imaging is not necessarily going to change what you do. All right, so I'm going to tell you that actually this is an extra-articular fracture. It's a distal 1/3, so we are really looking now at retrograde nails, or we're looking at a plate. And for those of you who looked at the cases earlier on, there's quite a lot of discussion about whether a nail or plate is going to be better. So what do we do if we're not sure? Well, that's what all these massive RCTs take on, and we can have a look at some evidence. And we certainly had equipoise when it came to the distal tibia in fixed DT, looking at nails versus plates. And there was a feasibility study done called Traffics to see whether we had the same amount of equipoise for distal femoral fractures. And interesting, the feasibility study kind of proved it wasn't feasible, because we don't have equipoise. For the distal femur, we as surgeons have quite a strong preference. This is a fracture I want to nail, and this is a fracture that I want to plate. The other thing that I thought was really interesting about Traffics is some of these fractures were managed conservatively. And there was a great question online, would any of you, even during COVID, manage this distal femur conservatively? 100% of you said no, but we know that it does happen from this. So we haven't got the evidence. Do we nail or do we plate it? Well, the surgeon doing this was really concerned about infection, because those ulcers are probably going to be exactly where your entry point, just like Pete showed in his photos, are going to be. So the plan was for a lateral plate. And this is again similar to another case. So have a look and what do you think? Because on initial sort of looking, you're like, whoa, this is AO-tastic, isn't it? I mean, it's perfectly reduced, length, alignment, rotation, you've opened it, you've lagged it anatomically, and you've got this great neutralization lateral locking plate. So all is going to go fine. Well, of course it's not. Otherwise, we wouldn't be here presenting cases which we can all learn from. So what might well happen? Well, certainly in my experience, what is initially is a simple spiral or two-part fracture. When it comes to the elderly, these are all massively multifragmentary, and there's no way that you're going to be able to get it anatomical. Also, those lag screws, you spend so long putting them into sawbone, we see the AO juice. Probably doesn't happen as well in osteoporotic bone, and I'm not sure that the compression that you've got across these. And then the other thing is the biology, all right? So in order to get this x-ray, it's all been opened up, it's all been stripped, and we've also just damaged all the sort of its healing potential. It's pretty rigid with some lock screws. So can we predict what's going to happen? Well, probably we can do. So this is just simply a loss of race against time. So distal femurs are going to take a long time to heal, and that plate is not going to be sufficient in order for the bone to heal. Is it just this construct of lag screws and distal plating? Well, no, because it happens quite a lot. Different strategy here done elsewhere. plate may be done by not opening the fracture, used in bridge mode. I don't think it's how you use the plate. I just don't feel that a single lateral plate is really winning your race against time. And you need a construct that's going to last a bit longer in order to let your bone heal. Your bone will heal. You just need metalwork to be a bit stronger. So what's the solution? Well, the solution is to move away from nailing or plating. And I think that if traffic started again, I don't think that we'd all be able to enter into it, because we don't do nails anymore. We don't do plates anymore. We don't do frames anymore. We're quite often using all three different techniques, because each piece of that hardware is doing something slightly different for that particular fracture pattern. So the solution is more metal work, so going to last a little bit longer as a nail plate construct. Well, does it work? This is just our series having a look with 40 plates versus 28 nails and plates. And you can see that the nails and plates were better in terms of metalwork failure and union. But I think the key message from this, and you guys were so honest on your survey about with the case with the periprosthetic, would some of your post-op instructions involve non-weight bearing? And the majority of you said yes. So we all go around in the meetings and we put our hands up. Yeah, we're aggressive. Of course, we weight bear them all, but secretly we don't. We still secretly are hoping we're right, touch weight bearing, get away with it. But with your nail plate construct, that's going to give us as surgeons a little bit more confidence to weight bear our patients. And we know that's what patients need. We would never do that for neck or femur. And the distal femur is really no different. So nail plate construct is going to give you more confidence to weight bear your patient early. So we're needing our metalwork to last longer. This is now just a few technical tips. I like to do the retrograde nail first, and I do my nailing in exactly the same way that Pete just described. You can either go for a relatively longer nail and a shorter plate. It's difficult to get your proximal locking around. So my preference now is to move to a slightly shorter nail and a longer plate for bicortical fixation at the top. And if I'm doing a nail plate construct, I tend to do my distal locking through the nail from a medial side, just so if I ever have to remove the nail, I can do so without removing the plate. There are some advantages, pros and cons of everything, as there is in surgery. You can do your distal locking from the lateral side, and certainly that stops your locking screws backing out because your plate's acting as a buttress. But I say my preference is to go from the medial side. And I tend to use screws so I can get variable angle screws and then plate around it, as opposed to using a spiral blade. However, I take Greg's point that if you're using a spiral blade with an end cap, you're going to give yourself a fixed construct. But the problem is arthroplasty, isn't it? All the arthroplasty is they love putting these knee replacements, and this was the case that was presented online. I think the majority of you said, look, this is a simple fracture pattern, so I'm going to cable it, get it anatomical, and do a single latching plate. But I've just said they're very, very unlikely to be simple, and we don't want to open it and strip it too much. And a single locking plate, or whether you lock or not lock, is not going to be sufficient to last long enough. So even with a periprosthetic, you can still do your nail and plate construct. Depending on the type of knee replacement and where that knee replacement sits in terms of its flexion and extension. Here at the top, we've used, I think these are fantastic. I'm much better at screwing than I am at wiring. So I'd prefer to use these locking attachment plates for bicortical small fragment screws around the nail, rather than periprosthetic screws or unicortical or cerclage wiring. So which knee replacements can we do it? And certainly I've spent a long time looking up all the evidence, and there's a huge amount of papers out there looking at which knee replacements can you get a retrograde nail through. And they all tell you something slightly different. And of course, it's hard to keep up with it as new knees are coming out all the time. But universally, they tend to say that it's a no-go for a next gen, although I beg to differ. So this is distal femur. You can see from the middle x-ray that it's spiraling down. It's a well-functioning total knee. And we can get a guide wire through the same MEPO percutaneous approach. But you'll notice the really important thing, that the entry point, and we've heard from Pete how important the entry point is, the entry point is wrong for a nail. I can get a nail through it, but a consequence of your bad entry point is, if you look on the far right, I've ended up with an apex posterior deformity. So it's okay. I mean, length, alignment, rotation, not opening, it goes on to heal. But because the entry point of the nail is wrong, you're going to increase the deformity at the fracture. Now, fortunately, there are some new technologies on the horizon, these periprosthetic nails with an increased 10-degree curve, which are going to allow for a more posterior entry point. And I really do think this is going to push now what total knees you can nail through. This is as a washer, known as the locking attachment washer. I'm desperately trying to beat Pete to be the first one to use it, and Ennis, Greg probably already has. And this may mean that for those ones that aren't quite so distal, that we can be using this instead of the full lateral plate. Right, so does it all go to plan? Well, absolutely not. This is pushing the indications for what's nailable. I thought, well, I can probably nail that. We know it goes into the joint. We can fix the joint first and then pop a nail through. I didn't do that. I was very horrified when the nail still came out through the trochlear. And I thought, well, I better not leave it like that. So what's the plan B? Is my plan B still my single lateral plate? Well, no, I don't want to do that because I know 40% are going to fail. So then I moved to a lateral plate, but instead of supplement with a nail, with a medial plate. Now, currently, for where I'm working, we don't have a pre-contoured medial plate. Of course, you can use a straight LCP, but you may only get 1 or 2 screws in your distal fragment, and sometimes the fracture pattern is not really amenable to buttressing. So we did a little bit of work working out which plate sits on the bone, and we've realized that it's the ipsilateral, the same side, lateral proximal tibial plate is the one up until about 12 centimeters that fits quite predictably without any lift off with a lot of screws distally. So that's me coming to the end. So what do I want you to take away from it? Well, I want you to take away that actually a single lateral plate for elderly distal femurs is really not enough. You need to add it ideally with a nail, but if not, consider a medial plate. Early weight bearing is paramount. Don't kid yourself. Be confident and do a construct that lets your patient's weight bear straight away. Don't open it. We don't want anatomical. We want length, alignment, and rotation. Don't worry about our next gen. I reckon you can nail through it. And on the horizon, there's new technology which are going to push our indications for retrograde nails even more. All right. So I guess back to you, Pete.
Awesome. Thanks, Jayne. So be honest, because I totally agree with this. It was lovely to see everyone go, yeah, actually, I don't actually weight bear all my patients, even though a lot of people, all of us are guilty of banging the gong of like elderly patients need to weight bear. And then, and yet still, we are quite a conservative bunch, aren't we? So Jayne, having done your 2 plates or your nail and plate, does the op note say weight bear as tolerated? Is that what you write in the op note?
Yeah, no, absolutely. And then all those cases were done by us as the trauma team over at Coventry. And I say there was only 1 case that had a nail and plate construct that the surgeon didn't write. In fact, we would just write fully weight bear.
Right. Greg, what are your thoughts on nail plates and plate?
Well, I do them quite often, actually. I'm actually doing dual plating constructs or nail plate constructs in, excuse me, some younger patients who have substantial amounts of metaphyseal comminution about their distal femur fractures. So, but yeah, I think it's been fantastic. I've had too many distal femur fracture early failures and fracture non-unions come to me in Barris from elsewhere that they would have been salvaged, I believe, probably by a second plating construct placed medially or by a nail. And I am letting them all weight bear as tolerated immediately.
Ennis, can you just clear this one up for me? You know, the idea of a lateral locking plate, or indeed a nail, when you're teaching on an AO course or a bridging plate, a plate in bridging mode, is that you get a relative stability. You got a bit of movement at the fracture side, and that produces callus. What on earth are we getting with a plate nail or a plate construct? What kind of stability is it? Relative? Is it still relative because it's the bone still has a bit of give in it? What do we teach our students?
Yeah, and I think it's still relative stability because you're still bridging the fracture. You've just got a stronger metal construct. Your race against time is slightly more in your favor for those convoluted fractures. I mean, I think the mistake often comes with apart from the weight bearing issue about what you write in the actual op note, I think the other issue is how much people are opening up the fractures. So to get proper secondary bone healing and callus, we need to avoid opening the fracture. So no lag screws, no kind of wandering around and just trying to reduce it a bit semi-open. You know, you really want to try and do all percutaneous, so you maximize your biology.
Jayne, something you brought up there, and there's been a few questions around this, around where your nail. So you were saying you're going for a fairly shortish nail and a longish plate. What was it that took you to that rather than a longish nail and a shortish plate? Presumably you're trying to protect as much of the femur as possible.
Absolutely. So I think whatever you go for, you want to go for as long a fixation to span the whole femur as you can do. If you go for a very, very long nail, and you alluded to it in your retrograde nailing top, it makes your AP locking actually quite challenging, because especially if you've got a big belly, sometimes the belly is getting in the way.
Yep.
But then your screws on your lateral plate, you're going to have to do something slightly differently. You're either going to have to angle them around the nail or use a locking attachment plate. Whereas if you just stop your nail a little bit shorter, your plate's going to go up to the GT, not so much that you have to contour it round. And then you're just going to open up that bit and you've got 4 bicortical screws just done, no problem. And yet your AP locking is slightly easier on your retrograde nail.
Srinath Ranjit's asking that question that's kind of on everyone else's lips is will the next generation of nails, and we know J&J's brought one out and I'm sure the other companies will follow, but bring out ones that have more stability in the block. They've got, like, as you say, Greg, they've got bits of plastic in the things that turns into fixed angle screws, plus you've got bolts that sandwich on the side, plus you've got that accessory plate that Jayne talked about. Is that going to get us past the nail plate thing, do we think? Or do we, I guess we just don't know, do we?
I don't think it will with the fragility fractures, but I swear I see that sort of locking washer coming in would be for the distal femurs in young people, where you need a little bit of extra fix, but maybe you don't want to go to the whole long lateral plate.
Greg, you buying that?
Yeah, I agree. I apologize. I didn't hear everything because I'm writing some answers to some questions here, but yeah, I think that if we really think about the idea of doing laterally based lock plating, we're talking about asking these plates to act as a tension band types of constructs. And in order for tension band to function properly, you have to have good cortical contact on the opposite side. And in this case, not only do we have really poor bone because the quality stinks, because the patient's elderly, but also half the time there's a bunch of comminution. So you just can't rely on that. So it almost doesn't matter how wonderful of a newfangled construct, some next generation super plate that goes on. I still suspect we're still going to need to provide support elsewhere.
Great. All right. Someone's asking about a distal femoral toma fix. I've got no. That's an osteotomy tool, isn't it? I've not used that myself. It is quite a robust plate, but it's a very rigid construct, I would say.